Hi, welcome to another Tuesday talk at Kim's Herbs and Detox here in Olivet. I'm Amanda LaPlante. I am an integrative health coach and my practice is called Get Real to Heal. It's here in St. Louis. And I've had the pleasure of being here several times for Kim's talks over the last couple of years and love what she's doing in the community. So I want to thank her for having us out. I am not the star of the show tonight. The actual star of the show, as he should be, is Dr. Michael Twyman, a board-certified cardiologist who owns Apollo Cardiology here in Clayton, Missouri. He does phenomenal work as an integrative cardiologist and a biohacker, and I don't know how much of that he's going to get into tonight, but he's going to give us a ton of great information, and I'll let you take it from here. Glad you're here.
Well, thank you everybody, and thank you for having me out tonight. And tonight I'll chat a little bit about high blood pressure and some of the things you can do to reduce your risk of having an event because of high blood pressure. But you know, I don't actually know how long this is going to go for. I haven't actually given this version of the talk, so maybe it's going to be 20 minutes, but I'll definitely leave enough time for Q&A and whatever you guys want to ask, we'll answer tonight. But again, thank you for your attention. And first off, blood pressure, what is it? So your heart is a muscular pump. Every time it squeezes the blood out of the system, it goes into the aorta. The aorta is the major blood vessel that leaves your body and pumps the blood to your brain, your arms, and down to the rest of your body. So every time the blood squeezes out of the heart, that's called your systolic blood pressure. That's the top number on the blood pressure. And as that blood goes out into the aorta is like an accordion. It stretches and then it relaxes. And as it relaxes, that's the diastolic pressure or the relaxation pressure. That's the bottom number. So 120 over 80, and 120 is the millimeters of mercury, the pressure leaving the heart. 80 is that pressure that's still hanging out in the aorta and pushing it against the heart. So that's one of the risks of when you have real high blood pressure, is that it's forcing the heart to work harder. And we'll get into some of the issues when you have high blood pressure for long periods of time. So I should also start with, how do you actually measure blood pressure? Because I would suspect that most people haven't actually had the blood pressure checked the absolute right way. And I'm guilty of it as well. I didn't really learn this until I went to an advanced cardiovascular module, and Dr. Mark Houston showed me the real way how to do this. He made me the guinea pig, sit me in front of the class and showed me how I've been doing it wrong for many years. But if you absolutely want to know your true blood pressure, it should be done, likely it's going to be done first thing in the morning relatively, because you should ideally be caffeine-free, nicotine-free, and alcohol-free. If those three things are in your body, your blood pressure is going to be higher. So blood pressure should be taken when you're in multiple locations, but if you're at the doctor's office, you ideally should be able to rest 5 minutes before you check your blood pressure. So this typically will happen when you're in the hospital or many offices. You run in there, the medical assistant slaps something on you, hits a button, your blood pressure's high, you've been running, trying to find a place to park, and you're all anxious. That's normal that your blood pressure is going to be high that way. But to get a true accurate blood pressure before your doctor makes a decision on, hey, I'm gonna add a new medication to your regimen, you really want to be resting for at least 5 minutes ideally. And then when you're sitting down, you want to have your feet flat on the ground like that, sitting up straight and your back supported. So if you're sitting on the end of an exam table and your legs are dangling and your back's not supported, your blood pressure is going to be higher than it naturally is. So once you're in this calm position, you should have an arm blood pressure cuff. The wrist ones, they might work, but they're typically inaccurate in my experience. So if you have a wrist one, it's always best to bring it into your doctor, my office if you see me, and we can monitor that your home blood pressure machine is the same as what we're doing in the office. It's okay to use an automated machine to kind of get a baseline, but you want to have it calibrated against a real blood pressure machine where somebody has a cuff on your arm and is using a stethoscope to actually listen to the blood pressure. So you can measure the blood pressure manually with, look like a little air needle moving. Those are generally pretty good. The old school mercury tube ones are probably actually the most accurate. Those have kind of fallen out of favor, and it's really hard to find at this time. But if you can find one that has an old mercury tube, that's going to give you the best measurement for your blood pressure. So after you've had your blood pressure taken, before you make an adjustment in your medications, your lifestyle, you need to have 2 abnormal results before you truly make a suggestion to say, okay, let's do something about this. Now if your blood pressure is 200 over 100, that puts you at high risk of stroke. You're going to need to do something on day 1. But if your blood pressure is borderline high, maybe just work with your lifestyle initially before you have 2 that are consistently high and you haven't improved it with lifestyle or your supplements initially. But the other thing is that there are different forms of blood pressure that people might have heard of, white coat hypertension. So you come into the doctor's office and you say, my blood pressure is always high when I see the doctor. that's why I don't even wear white coats anymore, because you can't blame my white coat for causing it. But that's not uncommon. But I tell patients you're still at increased risk, because if your blood pressure is high when you see me in the office because you're stressed, when you're out in the parking lot and you're out in traffic and you're stressed, your cortisol levels are high, your adrenaline levels are high, your blood pressure is going to be going up. So just having high blood pressure in your office doesn't give you a free pass that you don't have risk. So for people who have white coat hypertension, they should be routinely monitoring their blood pressure at home to see what it truly is. There's I shouldn't say random, but there's movable targets on what an optimal blood pressure truly is. They changed the guidelines in 2017, and they took into account a trial called the SPRINT trial. And the SPRINT trial was done in patients who were not diabetic, and many patients were older than 65. Many times they don't do studies in older populations, but this was a pretty broad spectrum of people. And they were measuring, is it more effective to lower people's blood pressure to less than 120/80 or 140/90, which is kind of the ballpark where people should be shooting for. And the study showed that if they could get them down to 120/80, they did significantly decrease the risk of heart attacks, strokes, and death. So 120/80 should be the goal for most people. So 120/80 is normal. Between 120 and 130 on the top number is borderline. 130 to 140 is stage 1 hypertension. Over 140 is stage 2 hypertension. And it's the stage 2 hypertension people, you gotta start be thinking about using medications sooner than later, because the higher the blood pressure, the higher the risk. So, if you have high blood pressure in the office, but not at home, so you got 120/80s at home, okay, I'm gonna trust your home values more than just one off in my office. But there's also something known as masked hypertension. I don't see it routinely, and unless you monitor for it, you're never gonna find it. It's where you have normal blood pressure in the office, but you have high blood pressure at home. So you can find that with people monitoring themselves at home. And then there's also something that is a medical device called an ambulatory blood pressure monitor, 24-hour blood pressure monitor, where you wear this blood pressure cuff, has a little battery pack like an old pager, and it goes off once an hour, record your blood pressure. And once you're at home and you're awake, you just let your arm hang loose and it takes the measurement to go back to what you're doing. But then when you're sleeping, it's measuring your blood pressure. And so one time I wore this at home just to see how bad it would be. It woke me up a couple times, but it wasn't that bad. I was able to go back to sleep pretty quickly. But you really want to know what is your average blood pressure through a 24-hour period, and especially what is your blood pressure at nighttime, because your blood pressure should naturally drop by about 10-15% as you're sleeping. If your blood pressure is staying high or it goes up as you sleep, that significantly increases the risk of heart attack and stroke. Statistically, most heart attacks and strokes happen between 3 a.m. and 5 a.m. because that's when the body's getting prepared to wake up that day. So you're raising your cortisol levels, you're raising the other alert hormones, and that's raising your blood pressure. So if you're already starting with high blood pressure and your blood pressure starts spiking, that puts you at increased risk of events. And by events, I'm meaning heart attack and stroke mainly. So that's the main issue with blood pressure, is that uncontrolled blood pressure wears out parts faster than you want them to wear out. So, this head to toe, if you've had an MRI or a CT of your brain and they find white matter changes, those are indications that you potentially had small little strokes in the brain. You might not have had any symptoms, and you might not have any deficits, meaning weakness or speech issues, but that's evidence that your brain is being injured by the high blood pressure. You could have plaque in your carotid arteries. You could have plaque in your coronary arteries. You could have issues with your retinas or eyes. Your kidneys could be failing from high blood pressure. So those are things that if you have end organ damage, you have a thick heart, a weak heart, blood pressure is usually the #1 contributor to that. So that's why you want to have a normal blood pressure. So, now we'll kind of transition a little bit into, what can you, do about it. I frequently talk about kind of the 4 pillars of health. Usually talk about that more as a factor for reducing the risk of cardiovascular disease, coronary disease, but it's also very applicable to hypertension. But it's how you move the body, how you feed the body, how you sleep, and how you deal with stress. All 4 pillars are extremely important, and we'll touch upon all of them. So, nutrition, the DASH diet is probably the most preferred diet for people who have hypertension. The DASH diet stands for the diet to something stop hypertension. You can just go online, type in DASH, D-A-S-H, and there's now a DASH 2 diet. It's very similar to the Mediterranean diet. It's going to be all the things that you're always, told to eat. A lot of healthy fruits and vegetables and healthy oils and, lean proteins and such. And it's going to be a more of a low sodium type diet. Sodium is a little bit of a controversial topic. Not everybody is salt sensitive as it sometimes comes out to be. So, but if you're one of those people that, sodium makes you swell or your blood pressure is high and you cut sodium down to less than 2,000 milligrams or 2 grams a day, then you need to be somebody who is more salt restricted. But more people than not don't need to be as restricted as the guidelines generally say. But a DASH diet is, like I said, the preferred diet. But if you're doing paleo or vegan, there's versions of you can do that also will tend to help lower blood pressure. Exercise is important. As you move the body, you're pumping blood around the system, you're strengthening the heart, and the blood vessels release nitric oxide when you exercise. Nitric oxide is a gas that dilates your blood vessels. If you can release nitric oxide, the arteries are healthier, they're less likely to be damaged by the high blood pressure. So exercise, is not just walking. Walking is good activity and everybody should be active, but exercise is something where you cause an adaptive response to the system. You cause a stressor and then you recover from that stressor. So it does require getting your heart rate up, maybe 70% of your maximal heart rate for a cardiovascular benefit. And then, if you have orthopedic injuries that limit you, then, water aerobics or recumbent bikes, whatever you can, do with limitations is fine. But also really consider doing some resistance training, because the more resistance or strength training you can do to build up your muscles, the stronger the frame that you have, the less likely you are to fall, less likely to be injured. The more muscle mass you have, the better your metabolism tends to run as you age. Because if you have a weak metabolism, you're more at risk of diabetes. That also increases the risk of blood pressure. So when you get diabetes and high blood pressure, that's kind of like fire and gasoline. That's much more risky. So strength training is important to building your muscles. Stress is ubiquitous. Everybody has stress in their life, and it's how you deal with it determines if you have an issue with it. So, there's a nervous system, the parasympathetic and the sympathetic nervous system, and that sympathetic nervous system is your fight or flight response. So, if you're in traffic, you have a bear chasing you, your heart rate, your blood pressure goes up because you need to get away from the bear. But when that acute emergency is over, you need to get that back down to normal. So when people get kind of stuck in that high fight or flight response, they tend to have higher blood pressures long term because of that maladaptive response to having really high cortisol and adrenaline. So your parasympathetic, one of the things that stimulates it is your vagus nerve. And you can stimulate your vagus nerve by deep breathing exercises, meditation, yoga. Put the head up here. Yep. Pocket. There's a device called HeartMath. HeartMath is a device that I routinely recommend to patients who have high blood pressure and have issues with stress. You basically clip this onto your ear. It plugs into your phone. There's a little app that you run, has different little breathing exercises, and it helps rebalance your autonomic nervous system through these breathing exercises. And you get immediate feedback that it's working. So if you go to the HeartMath website, there's significant data that this can help lower blood pressure without taking prescription medications. And then sleep. So sleep is extremely important. Without sleep, your body doesn't recover. And sleep might be the most important thing for longevity. So if you don't sleep well, it's much more likely you're going to have higher blood pressure because you didn't get to repair the self at night. But first off, make sure you don't have a medical reason why you can't sleep. So if you have apnea or you stop breathing at night, that can put some tremendous stress or strain on the heart, and then you're going to raise these hormones that raise blood pressure. So if you stop breathing at night, you need to get a sleep apnea test. There's home versions now that you can do. They're usually fairly affordable, maybe $200 or so to do a home sleep study. That's $200 if your insurance didn't cover it for some reason. Most time insurance will cover it if you have high blood pressure or risk factors for apnea. But the home studies, they look like a watch, usually have a little finger probe and something that clips to your chest or your ear. And then it monitors your oxygen saturations, your heart rate, and your movement, and can tell you, do you have apnea? If you have apnea, then treatment options include mask, CPAP mask that blow air down the airway to keep it open, or if it's a less mild case, it can be a mandibular device where it's like a mouth guard that just pulls your jaw open. So if you have apnea, get treated, your blood pressure tends to improve. But if it's not an apnea issue, focus on getting good quality sleep. That usually requires having pretty good sleep hygiene. So to the best of your ability, try to go to bed at the same time and wake up at the same time 7 days a week. If you start shifting it around on the weekends, you actually develop something called social jet lag. It's very similar to just what we just went through this past weekend with daylight savings time, where your body jumps forward, but not all the systems have caught up yet. And that's why you kind of have that lagging sensation for 2 days till you kind of reset the systems. But focusing on timing of your sleep is important, and then resetting your circadian rhythms, your 24-hour cycle. That can help you get that sleep hygiene tuned in by seeing the sunrise. The sunrise sets the rhythm for the day. That sun that enters your eyes programs certain hormones from the brain that gets you ready to go to sleep 13, 14 hours later. So see the sunrise through your eyes without contacts, glasses, and that can help with your sleep. And then at nighttime, once the sun sets, naturally you wouldn't have been exposed to a lot of bright light. Only until they invented the light bulb in the late 1870s did you have a significant amount of light at night. You would maybe had candles and campfire, but that's much more low intensity. That's red light. The bluer light is more intense, and that's the light that tends to come from your artificial lights and these technologies of screens. So if you've seen me in the office for the past 3 years, I've always had a pair of glasses on when I'm inside. This is just my newest version I'm wearing, so these are a particular brand of blue blocking glasses that filter out the light from the artificial technology. So when you block that light, you're able to keep your melatonin levels higher. Melatonin is the hormone that initiates sleep, but it's the hormone that actually kind of repairs the cells while you're sleeping. So if you run out of melatonin, you're not going to sleep very well, and your body's not going to repair itself. So controlling your light environments is key to protecting that melatonin. And then, I won't go too much into the other part of the circadian rhythm. The other thing that sets is the timing of your meals. Doesn't have as much data affecting blood pressure, but if you're trying to change body composition, your blood sugar, or your sleep quality is not that great, you want to probably constrict your time of eating your meals to 12 hours or less a day, meaning that anything that goes in your mouth that isn't water in the morning time starts the clock. 12 hours after that time, try to stop, and try to have 3 to 4 hours where nothing's going into your system before you go to sleep. That gives your body time to shut off certain clocks in your liver and gut and get you ready to recover and sleep for the night. Should go into a little bit of other risk factors. If you have insulin resistance, prediabetes, you have high cholesterol, you have overabundance of caffeine, you drink more than 1 or 2 alcoholic drinks a day, or you smoke, those are all triggers to your body that are causing the blood pressure to be up. So you always want to try to figure out if there's a reversible cause. Well, try to get rid of the cause before you consider putting on a medication to somebody. So after the stimulant is removed, if your blood pressure is still over 140/90, if you're fairly low risk of a heart attack, it's reasonable to start prescription medications at that point. If you're already higher risk of vascular disease, or you've already had a heart attack, stroke, you need to kind of be on medication sooner than later if you can't get things under control, and you want to shoot for 130/80 being the kind of the time where you should be considering medications if you can't get it under control with your lifestyle and your diet. There are different classes of medications for blood pressure. Typically, most blood pressure medications are only going to lower your blood pressure maybe 5 to 10 points each. So it's extremely common that if you get put on a blood pressure medication, that you're going to likely to be on 2, if not 3 medications sometimes to control blood pressure. It's rare that your blood pressure is controlled with just 1 medication. So it's not a big deal. I shouldn't say it's not a big deal, but it should not be alarming that if you get on 2 medications. But if you're on 3 medications and they can't get it under control, then they need to start doing a bigger workup for secondary causes, because there's some rare causes where there's certain hormones they release from adrenal glands, or certain blood vessels get pinched off at the kidney level that can increase blood pressure. So, your doctors will be aware of those tests, that it's not, the normal responding well to the medications or your lifestyle. Sometimes you need to go down the secondary pathway to look at it. So this is kind of the end of the formal presentation. I am recording this. I'll put it up on YouTube tomorrow. So, if you would like to follow me online, I'm on YouTube, Michael Twyman MD. I'm on Instagram, Dr. Twyman, Dr. Twyman. That's where I put most of my biohacks, is on Instagram. Biohacking is just health optimization, things you can do to optimize your health that don't require necessarily to take pills or procedures. So, biohacking in my mind, is mostly about affecting your light environments and controlling your environment at home and your work to optimize your health. So it doesn't require you to buy fancy gadgets or a bunch of fancy things from the biohacking guys. But if you follow me on Instagram, that's where I put most of this stuff. as Amanda said, I do have an office here in Clayton. Apollo Cardiology. Apollo was a sun god. He was also the father for God of medicine, so it made sense since I'm so big into talk about life and health. So I do focus on heart attack and stroke prevention. I definitely manage hypertension, manage lipids, prediabetes, but I really try to help patients find out where they're at and try to prevent them from ever going on to have the heart attack and strokes. So if you're interested in working with me, I'll be around after the Q&A. I also left some cards up here for you guys. But again, thank you for your attention. So.
Thank you.
All right, 20 minutes. That's what I
Can you
expected.
repeat the host and president?
We'll be live on YouTube by tomorrow morning. So. Yes,
I do
ma'am.
have one question. This one actually came up, I think today or yesterday in one of my groups. No, not a group, a young lady posted her blood pressure reading, which is really, really good. But somebody posed a question, not actually posed a question, they said they had heard that the diastolic number has actually been lowered from 80 to something below that.
And
The
so,
recommended kind of, and it was kind of like, that's what they had heard.
correct. So that's why I said it's sometimes a moving target depending on which organization is coming out with the guidelines, because the risk actually starts increasing after your blood pressure increases over 110/70. But there are no guidelines that say people should be on medications to push a blood pressure down that low naturally. Now, if your blood pressure is naturally that low, great, your risk is extremely low. But the risk is almost logarithmic, and that as the blood pressure goes up, the risk keeps continually going up. So for aggressive, you would push it down to lower than 80.
So 110 over, you said 110.
Yeah, 110/70 is where you'd optimally like to see a blood pressure without medications. If you're on medications, bare minimum 130/80, but optimally probably 120/80 is kind of the newer guidelines.
I'll post that when I get back.
And that's pretty,
I think that was a
yeah, I
question.
mean, that's the,
Yeah.
the sprint trial, this is where the data
Mine
comes
last
from.
week was 108/72, so it just.
That's not too bad, I would take that one all day long.
So which number is more critical? People say the top number or the bottom?
It sort of depends, and honestly, they both are important. The top number tends to be more important as you age, the bottom number is more important as you're younger. But when the top number gets high enough, it's mostly stroke risk and also heart failure, where the heart just starts getting, heart failure is not where the heart truly, quote, fails, but the heart either can't squeeze effectively or it doesn't relax effectively. And relaxation actually happens more commonly, that problem, where you have diastolic dysfunction. The heart is very stiff and can't relax and can't fill with blood effectively. So both blood pressures are important, but that top number tends to end up being more important for heart failure and stroke.
Can you touch on some of the symptoms that are so different for women with, just heart problems or stroke or heart attack?
Sure. So as for hypertension, hypertension itself typically is asymptomatic. People do not have any symptoms, and that's why it's kind of a silent killer for many people, is they don't know they have high blood pressure and it's doing damage internally. So that's when you end up having end-organ damage. You're like, oh, I didn't know I had kidney problems, or what's wrong with my eyes? It's because the blood pressure's been higher for longer than you've known. But your question about, women have different symptoms, that is true. Yeah, women don't always present the same way as a man would with a heart attack. In the movies, there's always the guy grabbing his chest and falling down. That's not always, that common even in men. But if you have any type of sensation in your mid-chest area that isn't normal for you, it could be a pain, but it's not always described as a pain. It can be described as pressure and uncomfortable sensation, and sometimes it's just that it's in your back or it's in your shoulders or your neck. If it's something that you're not, or fatigue or shortness of breath, it's just something that's not normal for you, and it comes on either when you're under emotional stress or physical stress. So when you go out there and you're exercising and some type of symptoms come on in this general region, you stop doing the activity and the symptoms go away, that could be a warning sign that that's something going on with your heart and you need to get that further checked out.
So how does someone differentiate between heart attack and heartburn? You see it all the time, people go to the hospital and, they think they're having a heart attack and it's heartburn.
It's a great question. Again, sometimes, it's better to be cautious than not. And, I've seen numerous cases coming into the ER in the hospital, and it turned out it was a, esophageal problem, it was, acid reflux, and okay, great, it wasn't your heart, you didn't have a heart attack, but now we need to get you to the gastroenterologist to kind of fine tune why this is happening to you. Tip, for the acid reflux thing is stop eating early. Stop eating at 5 o'clock at night. Your acid reflux is likely to be significantly less if you're going to sleep at 9 o'clock. So stop eating early is one of the biggest tricks for stopping reflux. But the question is, it's more kind of listening to the story and what is their backstory. So if somebody has high blood pressure, diabetes, high cholesterol, and they come in with chest pain, you're more likely thinking it's heart than it is necessarily acid reflux. If it's a 22-year-old female, it's probably more likely gastrointestinal than it is a true cardiac issue. But again, it comes down to, what's necessarily triggering it. Because most heart stuff is not necessarily triggered by eating per se, but if you eat something within half an hour, the symptoms are really coming on, more likely it's going to be gastrointestinal. If it's with exertion, more likely it's cardiac. So you kind of look at the whole story. But once you actually show up to the doctor, as an outpatient, it's a different story. You show up in the ER, there's blood markers they can do, and EKGs, and can tell you, okay, we think it's your heart, you need to stay for the day, and we're going to do a stress test tomorrow or whatever, or no, we think it's pretty safe that this is low risk, you can go home and follow up with your primary care doctor then.
I knew the answer to that. I was just trying to share because that actually happened to me, the opposite,
Okay,
where I thought it was heartburn, acid reflux, because I didn't have high blood pressure, high cholesterol, diabetes, none of that. And when I got then into the blood work, they said I had a heart attack. So it was, it was the exact opposite. So I was surprised, and the doctors were surprised, and they were like, I can't believe you had a heart attack. Your blood pressure is still not high, it's this and this and this, but it was stress.
Wow.
I had taken on way too many projects at one time, and they all were culminating at the same time, and it was just work overload, so.
right, and it's sometimes terminology is important because to truly diagnose somebody with a heart attack, they need basically 3 things, and they should at least have 2 of the 3 things. One, a good story. I'm out shoveling snow, my chest is killing me, and okay, that makes sense. Then it's the biomarkers that do blood tests that show that there's actually been damage to the heart. And then there's the EKG. If your EKG shows evidence that likely the heart's having an issue, okay, then it was likely truly was a heart attack. But sometimes people have an abnormal test. The test is called troponin. Troponin is very sensitive. It's a protein that's inside heart cells, and it should never be necessarily seen in your blood system. But when heart cells die, it's like a balloon, they pop open and they spill out all their contents, and that's what they're measuring. The higher the level of troponin, the more heart damage that has been happening. So troponin can be high, irrespective of you actually having a heart attack. So, the ER will always check it if somebody has a chest pain story, and they may end up saying later on, okay, this truly was a heart attack, but not every troponin equals a heart attack.
So there's a possibility you really didn't have a heart attack?
No, I did. I
Yeah,
had
so-
surgery.
Okay, I'm not saying that you didn't, but I'm
So
saying,
you had one? I'm sorry.
Yeah, I had a torn artery.
okay, well then you had what's known as SCAD, spontaneous coronary artery dissection. Not common, but it's more common in middle-aged women, and it's where the artery doesn't have any blockages in it, but it tears, and it usually tears like spirally, and then because of that tear, blood clots inside the artery, blocking all the blood flow downstream. Sometimes, if they're lucky enough, they can go in there and they can stent it. Not always. Sometimes it requires open heart surgery to repair. So, not a common finding.
How do you know if you're going through that? Like, how can you?
You'd have some really bad symptoms. You're not going to be like, oh, I just thought this happened. Like, you just be like, I've never felt something like this before, something's wrong, and you go get checked out. They wouldn't be able to diagnose it until they went up doing an angiogram. So they'll either go into your leg artery or wrist artery, and they'll go take pictures, and they'd be able to diagnose at that point. Because most commonly, the artery has like little plaques on it. They look kind of like pimples on the walls of the artery. And you may have no symptoms until that pimple kind of pops. And when that pops, a blood clot forms. But in that case, most of the time that's what happens is the plaque ruptures. But in that case, you get in there, you take a picture and be like, oh, this is something different. And like I said, that's extremely rare. I think I only saw 1 or 2 cases in my entire training. So.
cholesterol, high cholesterol, and so many things to treat that?
So high cholesterol is extremely common, but is high cholesterol a disease? Not necessarily. Every cell in your body needs cholesterol, and your body wasn't put together that you put cholesterol in the system to give you heart attacks and strokes. It's mainly the inflammation from whatever is going on in your environment. So you're not sleeping properly, too much stress, your diet's not where it needs to be, or you're sedentary. Those things tend to cause more inflammation. Inflammation is just kind of your immune system always turned on, and things tend to wear out faster. Your arteries end up being on fire. When the arteries are on fire, cholesterol is going there to try to repair the damage. The cholesterol gets damaged, and then it gets stuck in the artery. So cholesterol, without it, you wouldn't live. You make your sex hormones from it. You make the outer shells of your cells, your membranes from it. You make your bile acids to digest your fats from it. But if the cholesterol gets damaged, that's the problem. So there's advanced blood markers you can do to monitor for the oxidized or damaged cholesterol. And it's also important to monitor what actually takes the cholesterol around the system, because cholesterol is this waxy substance. It really doesn't float in the blood. It's kind of like oil and vinegar would be. So there's these things called particles. The particles are like cars, essentially. There's LDL particles, there's HDL particles. So there's no such thing as good cholesterol, bad cholesterol. There's just cholesterol. There's stuff that takes it from the liver out to the body. There's stuff that picks it up, brings it back to the liver. But the LDL particles, are what wrap up cholesterol and take it out the body, deliver the payload. The body does what it needs with the cholesterol. The HDL particles pick it up like a dump truck, take it back to the liver to recycle it. So, people typically want to call LDL bad cholesterol and HDL good cholesterol. It's the LDL particle number that predicts risk. The more cars you have out on the highway going through your arteries, the more risk there is of a traffic jam, essentially. So it's not as important to know how many people are in the cars, it's just how many cars are out there on the highway, and the people are the cholesterol. So cholesterol by itself isn't the problem, it's the particles. And you need to monitor the particle, and it's a simple blood test that can monitor that. And then treatment for it depends on what the rest of the story is. If you have atherosclerosis, so you have plaque building up in your 60,000 miles of blood vessels, sometimes you need to be more aggressive with prescription medications at lowering cholesterol. But in my practice, I routinely do 2 tests that look at the health of your arteries. One is a carotid scan. One is a test called a CT coronary calcium scan. The calcium scan looks at if you have plaque building up in your arteries by monitoring if there's any calcium there. If there's calcium in your arteries, well, calcium is supposed to be in your bones. But if it's in your arteries, it indicates that there's been damage and there's plaque building up there. The higher the calcium, the higher the risk. So if you have a calcium score of 0 and high cholesterol, work on your lifestyle, supplements, and potentially medications if you had a familial reason that your cholesterol is extremely high. Because over time, that may put you at increased risk. But if you have a calcium score of 1,000, you're at very high risk of having an event. You have a 90% chance one of your arteries has a severe blockage. You might end up with a stent or bypass surgery. So those are the people that prescription medications have been shown to reduce events, reduce heart attacks and strokes. So if you're high risk, take the high risk type of medications that lower the risk. If you're low risk, work more on your lifestyle.
Can you talk about tachycardia? That's kind of what I deal with sometimes. It's weird. Like, I might eat, and then 2 hours later, my heart rate is just crazy. Have you seen that before?
I have, but what's causing it? It's going to potentially be some type of food sensitivity. So I always recommend people who have issues with heart rate to keep a log and figure out what they think might be the triggers. So if it's not caffeine, if it's not alcohol, if it's not nicotine, okay, then what are you actually eating that might be triggering it? There are some heart rate monitoring devices you can use at home. You don't have to go so fancy as getting the EKG version. That one's called Cardia. It's about $100, and you can actually record a heart rhythm strip. And then, because tachycardia is essentially just a fast heart rate. So, and it's not arbitrary, but I quote, normal heart rate is between 60 and 100. There's some outliers where less than 60 is normal for them. There's some outliers that over 100 is normal for them. But if your heart rate is consistently over 100, it's considered tachycardia. But there's many reasons for tachycardia. It can be sinus tachycardia, where the heart rate just gradually goes up. There can be supraventricular tachycardia, where the top chamber starts beating irregularly.
That's what they said.
The supraventricular tachycardia, your heart rate's like 60, all of a sudden it's 150. Yeah, you know, kind of that rapid jump up, that's a different thing. And then some people have atrial fibrillation, where the AFib, where the top chambers are beating 400 beats a minute, and the bottom starts beating very regularly. So they might be fast, but they might just be irregular. So sometimes you might need to do the rhythm strip, the EKG, to actually know which type of tachycardia they have. But you can get a pretty simple pulse oximetry device, just plug it on your finger. And also most automated blood pressures also have the heart rate monitor on them too, at least give you a number. And so you can just see, okay, my heart rate, you know, in the morning time is always 60, and then I ate, you know, cayenne peppers or whatever, and now my heart rate's, you know, 110. Okay, I'm, you know, sensitive to peppers or whatever. So know what your kind of average heart rate is, and then how much higher over your average is then.
I'm dangerous at home taking my blood pressure because honestly, I'll look at the number, I'm like, I get stressed, and then I do it 5 minutes later and it's higher, then I do it 5 minutes later, and it's, I go crazy.
That's
Yeah.
I'm like, I don't know how to do my homework.
Okay. I'll talk you down.
Yeah, and that's why I said at the beginning is that it needs to be 5 minutes if you know, kind of relax, feet on the ground. You know, if you're really worked up, the blood pressure is always going to be higher. So don't take it and expect that you need to do something about it. You know, if your blood pressure is high and you're,
I went to urgent care.
I've seen that. I've seen patients that, I mean, if you keep really worked up and your blood pressure is, you know, 200, you know, take some deep breaths, do what you need to do, come down, recheck it. If it's still near 200, okay, go get it checked out. But if your blood pressure is like 140, you know, talk to your primary doc, come see me, we'll figure out what's going on with it. But yeah, try to be calm when you take your blood pressure. Yes,
So
ma'am.
I have a good one, because they said, let me see, last June, my cardiologist, he diagnosed me with AFib, and I wore a heart monitor that they had given me at the ER, wore it for 2 weeks, and then the test came back, and he said, oh, you have AFib, and then ventricular tachycardia, whatever. And then I was referred to the electrophysiologist in August, 2 months later, and by the time I saw him, he said, no, he said, I think it's more vasovagal. I don't think you have AFib, you know, ventricular tachycardia, whatever it is going to be. So went on and they put me on metoprolol, took that, and so I followed up with him in December. So I'm sitting there talking to him, and he's listening to my chest, and he says, you don't feel that? And I go, no. And I said, what is this supposed to feel like? He said, your heart is just skipping a beat. It's just skipping. And I was like, no, I don't feel it. And he said, but don't worry about it. You know, it's not a big deal or whatever. And so immediately, of course, I came off caffeine, but I wasn't drinking a lot before then. So I haven't had caffeine since last June. So now it's to the point where even my resting heart rate, it used to be in the 50s.
Mm-hmm.
You know, whenever I would go to that acute care or something, and one lady, she used to say, she used to always ask me, a couple people would ask me, do you work out? And I go, yeah. And they go, I said, well, how do you know? They said, because your resting heart rate, it's, you know, generally about 50 or whatever. So now my resting heart rate is 40, 41, and I thought that was kind of low. So even when I was at the, you know, the clinic doing my visit the other day, she said, is your resting heart rate normally that low? And I go, no. And lately it has been. When I start working out in the morning, I'm testing this like 41, 42, and then it climbs to about 50, you know, get started. But so I went from super high now to super low. Is that normal?
Potentially, and this is something you're going to have to discuss with the doctor that put you on the metoprolol, because metoprolol, you know, blocks the signal from the top chamber to the bottom chamber of the heart, and so it acts as kind of a brake. So if the heart is racing away, it kind of slows it down. So it's probably an effect where you might be over beta blocked, and that's driving your lower heart rate. So when people say, oh, you know, your lower heart rate because you're an athlete, that actually takes a lot of physical exertion to get a resting heart rate in the 50s. I mean, that's, you know, hardcore cycling, long distance running type stuff. You know, I'm a weekend warrior, so I mean, my resting heart rate is not 50. But if your heart rate's in the 40s, it can be due to the medication, but there's also a concern sometimes people have, and I'm not saying this is what you have because I don't know your whole story, but there's something that where people can have something called tachybrady syndrome, where the heart goes fast and then naturally it's slow. So it's sort of like the wiring system starting to wear out. Those patients end up needing pacemakers to keep them from going too slow. And sometimes they use the beta blocker to keep them from going too fast. They're kind of just right. So first, they would just need to look at you. You know, they might need to put another monitor on you to see, you know, is your heart rate really going to be 40, 50 all day long? You know, and if it is, then maybe they can back off on the metoprolol or use a different agent.
Okay.
This
So
one.
what are the chances of getting off the blood pressure medication? And can you explain that device again?
Sure. So the chances are good if you kind of can really fine tune a few things. You know, if you get your circadian rhythms, your 24-hour cycles down pat, that will lower your blood pressure. So that means, you know, rising with the sun, stop eating with sunsets, and really controlling your artificial light. Because, you know, everybody here has devices. I have multiple of these things at work, at home. These devices, you know, are great to connect with their family and friends. These devices do have a health, you know, consequence, and it tends to cause inflammation the more you use these devices. Inflammation raises your blood pressure. So, you know, living, you know, the way Mother Nature intended, where you'd be more outside, getting more sunlight, tends to improve that. You know, if you have a sleep issue, you fix your sleep issue. If, you know, nutrition is important, but it may not be the most important thing for high blood pressure. It's really going to be a multifactorial approach, and I can't tell just by looking at somebody what that's going to be. It requires some blood markers and some other testing to really kind of fine tune it. But, you know, just off the top of my head, I mean, vitamin D deficiency, extremely common. The darker your skin, the more likely you are vitamin D deficient, because darker skinned people need probably 4 to 5 times more sun to make the same amount of vitamin D as a lighter skinned person. If you have low vitamin D, it's almost always associated with low blood pressure, high blood pressure, I should say. And it's not so evident that just taking a vitamin D supplement and getting your levels back to normal is necessarily going to affect cardiovascular events. It doesn't mean you're going to have lower heart attack and stroke risk just because your blood level is higher from a pill. If you get your vitamin D levels up because you're out in the sun, that will, because there's different components of the sunlight. The UVA radiation in the sun basically makes nitric oxide in your skin when the blood comes up to the top of the layer. When the blood vessels come to the top of the layer of skin. You know, when you start turning pink in the sun, that's your blood vessels dilating, because they want that sunlight to charge up the red blood cells. When the blood vessels dilate because of that, they release nitric oxide. Nitric oxide naturally keeps your blood pressure lower. So the healthier arteries are, the more nitric oxide they can release. But sleep and lack of vitamin D are probably the top 2 things. And then people who have metabolic syndrome, where they have issues with insulin sensitivity, they're pre-diabetic or diabetic, you know, that can drive up blood pressure. High cholesterol just by itself will raise up blood pressure, so potentially maybe you have to fix that if they have other reasons to lower that. So it really takes a multifactorial approach, but, you know, I've definitely had success in getting people off, you know, most of their medicines. You know, depends on how many they start with. You know, if they're on 2-3 meds, yeah, I probably get them down to 1 or maybe off. You know, if they have a secondary issue and they're, you know, end up on 4 or 5 blood pressure meds, maybe get them off a few, but it's really hard to get them off all of them.
Okay, how should we handle our devices at night? Because, man, that's my problem. And early morning, I open my iPad, I'm all on Facebook.
It's a great question. And that's basically why I you know, became the biohacking cardiologist. So, you know, biohacking, basically this thing of health optimizing, is I was doing a flight over to Thailand a few years ago, and trying to figure out, like, well, how do you not die from that jet lag? It's like a 12-hour flight. And came upon these articles that talked about wearing funny colored glasses because it helped reset your circadian rhythms. So then once I got back and realized that my, you know, jet lag wasn't nearly as bad, I thought, well, there must be something to this light thing. So I did a, you know, significant deep dive over the past 2 to 3 years on how you maintain your circadian rhythms. And it's all about how the light enters your eyes and hits your skin. And you were designed to be an outside being. 90% of the time you would have been outside up until about 200 years ago. Once we had light bulbs, people started moving inside, and now most of the technology keeps us inside. So the average person stays inside 90% of the time or more. You know, sometimes in the winter, you might be outside less than 5 minutes in a day. And even if it's cold out, there's still benefits of the sun by the color of the sun and the intensity of the sun. So you're not making vitamin D in the wintertime, but that light still programs the brain to make hormones at the right time of day. So the best way to do it is through an example. Is you wake up in the morning, if you wake up before sunrise, you protect your eyes. So wear blue blocking glasses. Once the sun rises, then you go outside, take your glasses off, get 5, 10, 15, 20 minutes of sunlight into your eyes. You know, you don't have to stare at the sun, just face east, you know, do whatever you need to do, drink your coffee, talk to your family, you know, and then go back inside. And then, you know, ideally throughout the day, I always do it because I'm pretty hardcore on it, is that anytime I'm inside, I always have these blue light lights on because I can't control what other people do with their lights and their technology, so I'm just gonna wear them. But once I'm home in the evening, I try to minimize the technology if I can, especially an hour before you go to bed. You know, no screen time an hour before bed. You know, my house is a little bit different. I have like red light bulbs and nothing blue at night, so you know, I kind of went over the edge sometimes on that stuff. But the average person, they can just put on glasses at night, just turn off most of your overhead lights, and just kind of use task lighting if you need to read or do something. But wearing the glasses at night, you know, will help. And then, you know, there are night shift modes and other things on your phones and devices. They work, but they're not sufficient enough. They're still letting a lot of light through. And then you know, for the morning thing again, is I just had to make it a habit that, like, you know, I'm well into at least well over an hour before I will touch my phone in the morning time. You know, I'll use it. There's a meditation app I want on the phone. I'll play that, but I leave the phone in airplane mode, so you know, there's no text from last night. There's no emails waiting for me in the morning that I need to, you know, get all worked up about initially. Like, do your morning routine, whatever that is. You know, I highly encourage meditation if you don't do it already. That will help with blood pressure. But if you have something else you'd like to do in the morning, do something. And then, you know, an hour later, then get into your social media and everything else if you need to.
Since you're talking about the lights, you know, fluorescent, LED, all those different types of lights, are some worse than others?
Correct. No, that's a great question. So I get that question a lot. Is, you know, what's the best type of indoor lighting? The answer is none. The second best is candlelight. Yeah. The second best is candlelight or fireplace. That's the second best. That's not always reasonable either. Then, you know, what's the least worst after that? It's actually the old school incandescent bulbs. You know, the old screw-in bulbs. Yeah, they're energy inefficient, but the energy inefficiency was that they were releasing a lot more red light and infrared light. That infrared light's the heat that those bulbs are putting off. So that spectrum, or those wavelengths, was more similar to sunlight than the energy efficient LEDs and compact fluorescents. So while they're energy efficient, they basically dialed up a lot of the blue light. That blue light looks white to your eyes and is very bright. But the blue light coming from your light bulbs are typically 4 to 5 times the intensity that the sun is. So when you look at those bright bulbs at nighttime, you're basically tricking your brain into thinking it's noontime. So you'll make different hormones and you destroy melatonin. You're gonna have a very hard time sleeping then. Most people have a hard time sleeping if they're staring at their bright lights at nighttime. So, you know, the LEDs and you know, compact fluorescents, they're the kind of the worst two offenders. I still have LEDs in my house, but I don't use them at nighttime. You know, I use them, you know, during the day if I need to, and it's off and on. And then, you know, at night, you know, if you need a, you know, night light in your like hallway because you guys have to use the restroom, they make amber bulbs or red little light bulbs that you can put in those night lights, so that won't interfere with your night vision at night. So, you know, consider that. Anything else I can answer for anybody tonight? Yeah, right. Red lights. Yeah, I mean, the best hack on it is doing at Home Depot or Lowe's. You can get a red LED bulb for like $10-15. You know, those bulbs. I don't know exactly what wavelength it's putting off, but so you're not going to use those as therapy, because you might see that, you know, some people talk about low-level light therapy, LLT, or PDM, photobiomodulation. So you might see like the Juve panels and stuff like that. Those more intense red lights are very specific wavelengths. They help with collagen production. They help with muscle fatigue and inflammation. The red lights has some very interesting health, you know, benefits, but you're not going to get that from an LED bulb that's $10. But that LED bulb that you can buy won't have a lot of blue light in it at nighttime.
Why is it that, okay, I work at a weight loss center, and we have people that have come in on 3, maybe 4 high blood pressure pills. And when we get them to lose 60, 70, 80, we got one guy, he's lost 212 pounds.
Awesome.
So, yeah, they're gonna do a story on it next week on Channel 5. So, if that's the case and his blood pressure is not anywhere near, and he has not been on his pressure medicine, then why does his doctor insist that he needs to keep taking it?
So his blood pressure got much better with all the weight loss?
Yeah, I mean, and he's not taking, we keep asking,
Oh,
are
he's
you
not
taking your meds? Nope, I'm not taking them no more, I don't need them. I said, well, oh, you better check with your doctor. And he checked with his doctor, and his doctor says, no, stay on them.
I'd say potentially seek a second opinion, but sometimes there's certain benefits of certain quote blood pressure medications that are irrespective of what it actually does to the blood pressure. So I don't know this person's whole story, but if this person's diabetic or has kidney disease, there's certain blood pressure medications that help those conditions. If that person's had heart issues, ACE inhibitors, they tend to help with making nitric oxide and they help the arterial health. People have other issues like AFib or heart rhythm issues, so they end up on a beta blocker that can affect blood pressure, but it's also controlling heart rate. Sometimes people are on medications that are called blood pressure medicines, but they're using it for some other reason. So just need to figure out what meds he's on and why exactly.
Well, it's about 10 of them, and
Okay.
about six of their doctors have said, no, you need to stay on it. I'll wean you off of when I'm ready for you to come on. Kind of like that.
What's that?
I was gonna say, you need another, well,
Yeah,
so
Just a second.
I will say this, Dr. Twyman's been my cardiologist for quite a while, and I've had the good fortune of being able to work with him over the last few months, and I think one of his favorite things to do, don't want me to put words in your mouth, but is to de-prescribe medicine.
Yeah.
So, yeah, it might be time for a second opinion.
Yeah.
Yeah, I mean, that's definitely true. I mean, I use the least toxic thing to put in your system because anything that you put in your body potentially has a side effect, even if it's a supplement. So you want to make sure you have a deficiency in something that you're actually treating with that. Because people can get over medicated, and once you get to I can't remember exactly if it's 7, but once you hit 7 meds, you're guaranteed to have a drug-drug interaction. So you end up taking more meds to treat side effects from a medication you're taking, and the same thing can happen with supplements. You don't know, if you're on 7 meds and 7 supplements, there's gonna be all these cross interactions that are happening. So you want to try to mitigate down to the barest minimum that have data that reduce mortality. Basically, it's definitely been shown that if you take this medicine, you're gonna less likely die. There's certain things that might be nice to have, but you take them off for a while and make sure that those side effects are going away.
What do you think about CoQ10?
Oh, yeah.
It's a great question. For blood pressure, I use it, but is it highly effective? I haven't actually seen it be highly effective. CoQ10 is a substance that's inside your mitochondria. I lose the bet because I said mitochondria. I usually try to not say it unless I have to, but the mitochondria, those are the organelles inside your cells. They make energy. CoQ10 is a substance that your body is making, but it uses CoQ10 basically to transport energy from certain parts in the mitochondria. And if you have low CoQ10 levels, the mitochondria just can't make energy as effectively. So CoQ10, when your blood levels are greater than 2, typically it will have some effect on lowering blood pressure. So if people are on long-term statins because they have an indication to be on statins can deplete CoQ10, beta blockers can deplete CoQ10. So those people should consider being on CoQ10 to at least get them back to baseline. So I will use it, but I haven't seen it be highly effective for always lowering blood pressure.
Yeah, I'm on CoQ and resveratrol, and my blood pressure is 117 over 73. So I was trying to get the bottom number down. So
Yeah, resveratrol is a very potent antioxidant. It's basically what's the antioxidant inside grapes.
yeah.
So when you refer to the CoQ10 and the energy levels, are we talking theoretically, are we talking physical energy levels?
How deep do you want to go down the rabbit hole? But it's
I'm just saying.
so it's more the what I'm saying is more the how much ATP or adenosine triphosphate that the mitochondria make. ATP is like the energy currency that the mitochondria make. There's something in the mitochondria that spins. The faster that the thing spins, the more energy that gets pumped out of the other side. So the faster that CoQ10 can pass the electrons, the energy source to that spinning top, the more energy comes out the bottom.
So mine could be depleted, like the metoprolol could be.
Possibly, yeah.
Could be
There-
affecting,
yeah, there's a blood test that you can get. You can check a CoQ10 blood level.
really?
And Quest does it, LabCorp does it. Yeah, shouldn't be more, I mean, even if you had to pay cash for it, it should be less than $20.
Oh, wow, okay. Yeah.
So people with congestion heart failure, CoQ10 would be great.
Yeah, so I mean, that's kind of going back to Stephen Sinatra's work, you know, his awesome foursome. You know, so if you have a weak heart, you know, about 1/3 of your heart muscle is actually mitochondria. And so if your mitochondria are weak, your heart is weak. So you do whatever you can to support the mitochondria. So I will use it, but I kind of have a new spin where I'm doing more of the kind of quantum medicine and the biohacking, where it's really, you get your circadian rhythms dialed in, you get the right omega-3s into your system, you get the right sunlight, you can reprogram the mitochondria. So the weak ones will die off, the strong ones will live and colonize and grow stronger. So you can do more with the light stuff than you can just with the supplement part, but I still use it with the people with a weak heart, at least short term. But CoQ10, magnesium, you know, D-ribose, L-carnitine, all these things can kind of shove energy into the cells so they can try to start working a little bit better. But it's, if you don't dial in your circadian rhythms, get your sleep right, your sunlight right, all those things aren't going to make a big difference long term. Yeah, sleep is the number one thing people mostly come to me for. They don't realize that that's their biggest problem.
Yeah, that's my biggest problem lately, sleep.
Yeah, I'm sorry? Yeah.
That's my biggest problem lately is sleep.
The sleep?
I mean, I sleep, and I guess the last couple of days I'm sleeping better, but every night I wake up at the exact same time twice. Some nights I wake up and I'm like wide awake for probably 30 minutes, and then I fall back asleep, but it's every night between 1 and 2 and then 3 and 4.
Talk to me.
Yeah, yeah. Yeah, I mean, it's, top of my head, it's three things. A, it's essentially you're running out of melatonin and you wake up 4 hours after you fall asleep. So
Sometimes
that's one thing. So control your light environments, especially at nighttime. So blue blocking glasses.
Gotcha.
So,
Okay.
yeah. And unfortunately, quality matters with the blue blocking glasses. So if you just go on Amazon, type blue blocking glasses, you're not likely to find the right thing. So the brands I recommend are Raw Optics, raoptics.com, TrueDark.com, and then a third one which I like, but the only fault is that they're an Australian company, so if you have something got shipped back, they take it back, but you're going to be playing a game that takes 2 weeks to ship back and get back to you, but it's Blue Blocks, BLUBLOX. They have frames that sometimes fit women a little bit better than some of the other companies.
I love those.
What was the second one?
True Dark.
True, okay, True Dark.
Yeah, those are the brands, if you've seen my older videos, those are the brands I was usually wearing.
Okay.
But yeah, you wear the glasses in the evening time, and I would not be surprised if your sleep quality improves. Second thing is if your progesterone levels are low, that's something that would require a kind of full hormone panel to do. And then the other one is, low progesterone, not uncommon in women. And then the other one is that you have higher cortisol than you should in the middle of the night. And you can do a salivary cortisol test in the middle of the night, like 3 a.m., and see if that's the problem. Those are three off the top of my head.
Did you ever get into meridians, like Chinese organ clock, things like that?
I
know
do
it
not.
kind of syncs up with some of the circadian.
It syncs up, but I haven't yet gone down that rabbit hole.
I have fallen down that a few times, and it seemed to help me. So, yeah, in addition to all those other tips.
Are you related to Tim, is that?
I can ask that question, but I am not.
Well, I think we're at 7 o'clock. I want to say thank you so much to Dr. Twyman for being here.
Thank you for the great questions. It was very good.
And I've been collecting, if you'd like to sign in, if you haven't already, and you want to keep in touch with Dr. Twyman, I'll make sure this gets passed